Welcome everyone, and thank you for joining us. Everything ALS presents our BCI webinar series for the month of June. We're very excited to have the BrainGate investigator team present on our June 16th webinar. You can register for our events at everythingals.org/events. Today, we're giving our audience a preview of the BrainGate Clinical Trial overview. I'm Lisa Deegan, and Nadia Sethi and I are both part of the Everything ALS team. I'd like to introduce our guest today. From the BrainGate team, we have Dr. Leigh Hochberg. He's a director of the BrainGate Clinical Trials and also a neurologist at Mass General Hospital, Brown, and Providence VA Medical Center. Also here with us is Dr. Daniel Ruben. He's a neurologist at Mass General Hospital and one of the investigators on the BrainGate Clinical Trial. Thank you both for being with us today to help our audience understand more about the BrainGate Clinical Trial. Thank you, and the floor is yours. Let's start with questioning. So let's get into it. What is the BrainGate study, and what is a pilot clinical study?
Sure, and thanks very much, Lisa, and thanks to everybody at Everything ALS for the opportunity to present to you today. I'm really looking forward to telling you a little bit about the BrainGate clinical trials today, and then to providing some additional detail, including some videos of some of our participants using the investigational BrainGate system a few weeks from now. So the BrainGate pilot clinical trials, or feasibility clinical trials, are assessing the safety and feasibility of an implanted investigational medical device, really seeking to ask the question whether somebody with ALS or other forms of paralysis might be able to control a cursor on a computer screen just by thinking about the movement of their own hand. Wow. I'll tell you more. Yep, go ahead.
Well, you talk as long as you want. I think it's fascinating, so I don't want to cut you off. You just let me know when you're ready for the next question. And I also have Nadia from our Everything ALS team. I'm sorry, I forgot to mention you in the beginning. She's amazing and is so knowledgeable about clinical trials. So it's great to have her here with us as well.
Absolutely. Nadia, it's good to see you as well.
Thank you. I'm so glad to be here.
This is an early stage study, which is always a little bit of a funny thing for me to say because it's an early stage study that is now, roughly speaking, in its 17th year. And I'll tell you more about the ongoing development of this BrainGate interface system in just a little while. But really, the goal of this trial in its current stage is to determine both the safety and feasibility of using a particular approach for allowing people with ALS or other forms of paralysis to control external devices just by thinking about the movement of their own hand. And then to learn over the course of a year or more how we can continually make that system ever better. And I'll describe that in a little more detail in a bit.
Super exciting. Okay, so can you please share with us who is able to participate in your trial?
Sure. So anybody who has received a diagnosis of ALS and has begun to experience some weakness in their arms and legs is, at least at a first pass, eligible to join us in the BrainGate clinical trials. That means that someone could be, at least theoretically, could join us in the trial fairly early on after their initial diagnosis, after there's some weakness of the arms and some weakness of the legs as well. But also we can recruit people through the progression of disease. And we have had people in our clinical trials who have a little bit of movement of their hands and who are able to speak. Some people who are often using a wheelchair, but sometimes are able to stand and pivot. We've also had people in the clinical trial who have been much further along in the disease with much more extensive paralysis. In fact, we've had people in the trial who have been mechanically ventilated, who've been unable to speak with very limited or no use of their hands. The one requirement important for people who have had more extensive ALS is that we do need to be able to communicate readily with anybody that is enrolled in the trial. So as long as somebody, for example, is able to use their eyes to communicate consistently, we're able to recruit that person into the BrainGate trial. Or, as I mentioned, we can enroll people who have received a diagnosis more recently and have less paralysis.
Okay. So with include, we want to be able to share with people before the webinar so they have a very clear understanding of the inclusion and exclusion criteria. Is there anything else you want to mention on either or both of those for folks to know about?
Sure. So generally speaking, we enroll people who are really joining us in the trial, not because they're hoping to gain any particular benefit from participating, but because they want to help us to develop and test a system that we all hope will help other people with paralysis in the future. And that's a really important focus, is that as I am able to tell you more about the technology a little bit today, and then more a few weeks from now, you'll see that it's really the interaction between the participants in our trial and the rest of our research team that helps us to learn how this type of system will be able to help other people with ALS. And while that perhaps isn't the strict inclusion criteria on the long list of inclusion and exclusion criteria, it's that perspective that is really important for anybody who's interested in learning more.
That really clarifies things. Thank you. So what would the time commitment for this trial be?
So let me describe just a little bit about the system itself, and then describe the time commitment, because I think that'll be helpful in that order, if that's okay.
Please do.
So the investigational device that we're working on, which we call the BrainGate neural interface system, uses a small chip, or sometimes we call it an array of electrodes, that record brain activity. And specifically, it records brain activity that is related to the intention to make a voluntary movement. For example, to move one's hand from one place to another. It also has the potential to be able to record as somebody is attempting to speak, or somebody is actually speaking or actually moving their hands. And the goal is to be able to capture the brain activity that is directly related to that either actual or intended movement, and then in real time to convert that brain activity into the control of an external device, for example, the control of a cursor on a computer screen, or of a tablet computer, or other useful communication or mobility technologies. I'll show you more about the device in just a little bit. I have one that's on the desk next to me. But to your question of how long is the participation in the trial, generally the people are in the trial for at least a year. We plan at the outset for the trial to last about a year. And then at the end of the year, if people are interested in continuing in the trial, we can continue on for an additional 5 years beyond that. And we have had people in the trial who've been in for 4 or 5+ years.
Oh, okay. And if I'm in the trial, how often would I have to visit the hospital or clinic?
So the device, which again is sitting next to me, and I'll show you in just a moment, is placed by a neurosurgeon. So clearly, in order for the device to be placed in the brain, that requires a visit to the hospital, and importantly also a visit to the operating room, which is where the device is placed by one of the neurosurgeons on the BrainGate team. Outside of that inpatient visit, which we generally expect to be about somewhere between 2 and 4 days, the rest of the trial occurs at home. We may ask somebody to come in prior to the day that we're placing the array to do an MRI, to do a CAT scan, to have an EKG and a chest X-ray done. But those are single visits that are generally, that can sometimes be performed all in one day, and that's an outpatient event. Then there's the one important inpatient event, which is the placement of the device. But the rest of the research, the rest of that year or more, occurs wherever that person lives. And so we come to that person's home. Some people in the trial lived in an assisted care facility. We go to that assisted care facility, and we're visiting and working with our participants, roughly speaking, about 2 days a week. We try to reserve about half a day. Usually doesn't take that long, but we reserve 2 days a week to come to the participant's home, activate the device, I'll tell you in a little while that the device can also be used when we're not there, but to work closely with the participant about 2 days a week over the course of a year. At the end of the trial, whether it be at the end of a year or beyond that, if the participant decides to have the device that was surgically placed removed, that of course also requires a return to the hospital for the removal of the device, and then that would really be the conclusion of the time in the trial. So, quick summary: nearly all of the research is done where the participant lives, in their home, in their place of residence. The few exceptions are an outpatient visit at the beginning, an inpatient visit to have the device placed, and then potentially an inpatient visit to have the device removed.
That's really nice. It makes it easy for the people that are participating.
I agree. And that's actually, that was very much on our minds when we designed this trial. Is there are a lot, and for good reasons, there's a lot of ALS research that happens in the medical center, in the university laboratory. But from day one, we've wanted to develop and test this device where it actually needs to work, which is in somebody's home, in somebody's living room, wherever it is that they may want to be using this device. And for that reason, we designed it from the outset for us really to be able to go to the participant's home.
Well, that's great, because it sure makes it a lot easier on them. So can you tell us if this trial is registered on clinicaltrials.gov?
It is. It has an NCT number. It's been on clinicaltrials.gov for years, and the easy way to search for it is to type in the word BrainGate, all as one word, or BrainGate 2, just the number 2 after it, all referring to the same trial.
So, and I'll just read out what the number is in case somebody's already up on clinicaltrials.gov. It's NCT 00912-041. So, okay, next question. What is the risk of participating in the BrainGate trial?
The device requires neurosurgery, and every surgery, whether it's neurosurgery or any other, involves risks. The risks that I make sure that I mention out front are the risks associated with anesthesia. And those are always important to consider. And for anybody who's interested in the trial, we have a extensive discussion, more than one, about the risks, particularly the risks associated with surgery and with having the device placed really into the top of the brain. And maybe to make this a little bit more concrete, I'll just show the device as best I can. And the reason I say as best I can is because it's really tiny. In fact, I have to make sure that I put my finger up so this is in the right way. So this is the device, and I'm twisting it around, and I suspect that it's not coming through all that well over the camera.
No, you can see how small it is up to your finger.
Yeah, so that is there's another view of it. So that's the BrainGate, or the Utah array, as it's sometimes known. And on that little platform, there are 100 tiny, very tiny electrodes. And it's the tip of each of those electrodes that, when tapped into the top of the brain, that have the ability to record from one or more neurons, and neurons that are related to the intention to move one's hand, or perhaps the intention to speak. That array is then connected by what is probably even less visible, this goldish wire, I guess it can be seen there, that are the little fine wires that connect the recording elements, that is the tips of the electrodes, to this pedestal, which is just a semi-fancy name for a connector. And I'll just place that here. So this connector sits on the top of the head and protrudes just above the scalp.
Okay, so you can see a little bump. Okay.
You can. So you can see, so we will generally place 2 of these devices now, 2 of these titanium percutaneous connectors, to use the full name, or percutaneous pedestals. It's really just a plug or a connector that allows us to record, then to place a somewhat larger device on top that allows us to record the brain signals when somebody is using the BrainGate system. I'll come back and tell you more in just a bit about how we record the rest of those BrainGate signals, the rest of those brain signals. But to your question of risk, it's the placement of this device and the chronic presence of this device that really is where we're focusing the questions of risk about. So in any surgery, including this one, there's the potential for bleeding. There's the potential for stroke. We think that both of those risks, or the likelihood of those happening in any way that would be clinically meaningful, are very small. There's the risk of seizure, which can happen anytime there's a surgery that's happening, particularly in and around the cortex. If that were to happen, we would expect that those seizures would be very easily minimized or reduced or eliminated by medication. So I mention all of those things because we think about them, and we wouldn't be engaged in this research if we thought the risks of those were anything but very small. Probably the risk that we think the most about, that we are constantly mitigating, and thankfully have been quite successful to date in doing so, is to reduce the risk of infection. There is a percutaneous device. There's a device that's sticking through the skin, and it is connected by some wires to an array or a recording sensor that's placed in the brain. So it's important for us, important for the participant in the study, for that skin, the skin that's around that pedestal, to remain clean. And in order to do so, we have a protocol to make sure that it's placed, of course, under a sterile environment in the operating room, but also then a very simple skincare protocol that takes less than 5 minutes, that can be done by any caregiver, to help to make sure that that skin that's around, or that part of the scalp that's around the connector, remains clean.
And I would think because it's made of titanium, the chances are pretty low for something going wrong because of having titanium in you, because I know they use it for, like, I have titanium in me, so I know, that's why I bring that up.
So the choice of metal was specific. This is an ongoing trial, so I'll be very careful not to make any true conclusions about safety. What I will say is that we wouldn't be doing this if we thought the risk of related to infection or any of the other risks was anything but extremely small. We have been doing this for, as I mentioned, about 17 years. There have been 14 participants in the BrainGate clinical trials to date, and I am really encouraged by the safety profile thus far of this particular device. I'll also mention that while we've been engaged in this for nearly 2 decades with this percutaneously connected array that's in the brain to allow somebody hopefully to be able to control an external device, there are also a few other universities around the country that, modeled in many ways off the research that we started, have been using the same device. And I'm fairly comfortable that the fact that there are now multiple groups who are able to pursue similar research means that thus far the safety profile of the device has been at least encouraging or comforting. So that was a long answer. I can assure you that we think a lot about reducing the risk of anything that unexpected happening or undesirable happening. And of course, the participants who join us in the trial engage in lots of discussion with us and thinking about what's the chance of anything unexpected happening, and then what would the clinical effect be if it did.
Yeah, okay, great. Thank you for that. So what tests and procedures are involved? You did mention how, there is a procedure involved to get the implant in, but anything else that you can share with our audience on that?
Sure. So as we're preparing for the day where the implant is placed, in the weeks or the month or 2 ahead of that, we would want to obtain a CAT scan of the brain, an MRI of the brain. That MRI, when we can, is a functional MRI. It's one that can show us some of the different areas of the brain that are becoming active as somebody attempts or actually moves their hand while they're in the MRI scanner. There's some blood tests that we draw. There's some skin tests that we collect to make sure there's no colonization of the bacteria that we would want to clear prior to surgery. And a chest X-ray that would be done. But other than blood tests, skin swabs, CAT scan, MRI, those are really the main tests that would happen before the day where somebody would electively be admitted to the hospital for the surgery. After that, the rest of the procedures, if you will, of the study is the use of the device in that person's home.
Okay. So with this, would hospitalization be required?
Hospitalization is definitely required for the day that the device is placed in the surgery, surgically, and we would expect people to be in the hospital for about 2 to 4 days afterwards. There's one person who at exactly hour 24 plus 1 minute said that they were done. They felt fine. They wanted to leave, and we said, okay, we'll generally encourage people to hang around for at least another day, and if for any reason it's useful to remain admitted for another day or two after that, that's something that we expect and we're prepared for. But generally speaking, we're thinking it would be about 2 to 4 days, including the day of surgery.
Standard. Okay. So if I'm in the BrainGate trial, does this exclude me from other treatments?
So there's almost nothing that that being enrolled in the BrainGate trial would prevent somebody from being able to enroll in. I think the only, and really the best way to answer that question is to flip it in some ways and to be asking the principal investigator, the study staff of other trials, whether they have any issues with being enrolled in the BrainGate trial with a device that's placed in the brain. I think there's two potential issues to consider. One is that there's a time commitment that's involved in this trial. So we're working with the participant in their home, sometimes remotely, I should say, even though I've said in the home multiple times, we are often there physically. Over the past year, for good reason, we've moved to remote for a lot of the interaction. I suspect we'll continue to do so, but our plan going in is to be working with the system there in the home. So for anybody for whom that 2 half-day-a-week commitment would interfere with the ability to participate in another trial, that would seemingly present a problem for being enrolled. The one other issue is that if there's any medication that's considered an immunosuppressant, one that would decrease the body's ability to fight an infection, because, as I mentioned, we're really focused on trying to minimize the risk of infection because there is a device that protrudes through the skin. If somebody happened to be using a medication, either one that is typically prescribed or one that might be involved in an investigational clinical trial, and that medication had a clear effect or side effect, either one, of decreasing the body's ability to fight an infection, particularly a skin infection, that would probably give us all pause.
Okay. So what happens when the trial is over?
So we're hopeful that when people join us in the trial, that that kind of the mutual commitment is that we're going to work together for a year. And then at the end of the year, which is a very kind of arbitrary time point, we then will purposefully just take a moment and say, well, should we continue? And if the person wants to continue in the trial, as long as the trial continues to be funded and we continue to have regulatory permission, then we pick up the next day and we continue. And as mentioned, there have been people in the trial for years. At the end, the trial at that point really ends when somebody says, hopefully, thank you, and this has been fun. I've really enjoyed being in the trial and really enjoyed contributing to the science of learning how to restore communication and mobility for people with ALS and other forms of paralysis, but I'm done. And now I'd like the device removed. We say, okay, and then we schedule a date for having the device removed. Again, in the OR, would probably be followed by a day, maybe 2 in the hospital, and then return home. The 30 days later, we would do one more of our kind of monthly checks to make sure that everything is kind of working as expected, and that there's no adverse events that we're monitoring for. And then that would, at that point, be the conclusion of that person's enrollment in the trial.
Excellent. Okay, so how do I enroll in this trial if I'm interested?
So first, I'll just thank everybody for tuning in again today and being interested in learning more about the BrainGate system and about the BrainGate clinical trials. Best way to learn more, a little bit more at least, about the trial is to go to braingate.org. There's information about the clinical trial itself, about some of the research that we've been doing. There are videos that are related to or that have been previously appeared in peer-reviewed publications, and there's a little bit more about the inclusion criteria that can be seen on that website. For people who are interested, please feel free to send us an email, directly. Friends or family members can email us. clinicaltrials@braingate.org is the email address. Telephone number is for the trial, 617-724-9247. Don't have to remember that phone number. It's on the website as well at braingate.org. And that begins a conversation. That begins a phone call with either Dr. Ruben or myself or Rose Marujo on the study staff, or the study which occurs, which I should mention in a few places around the country, one of the study staff from one of the local sites. At the end of that phone conversation, people are interested in learning more, we'll then schedule a longer phone conversation. That's often followed by a visit to the person's home, where even though I held up the device and showed it on the camera, give you a chance to see the device in person, learn a little bit more about the recording equipment. And then at that point, if people are interested and ready to enroll, we'll have an informed consent meeting and then begin to schedule for the preoperative tests and for the placement of the device.
Dr. Hochberg and Dr. Ruben, we're so excited to have you guys on June 16th. We cannot wait. So I hope people get to see this and get a really great preview of what's to come. I think, BCI, brain-computer interface, is so fascinating. What's happening now and eventually for the future for people with neurodegenerative diseases. This is huge, and we love what you're doing. And we appreciate you coming today and giving us your time. And we can't wait for the event. So we want people to register and come see our event, hear more from the doctors. And you can register at everythingals.org/events. And we'll do Q&A so people can ask you guys questions. It'll be great. So we appreciate your time and can't wait for the webinar. So June 16th, folks, tune in, right?
Thank you so much. Thanks for the opportunity. Lisa, Nadia, thank you.
Thank you, guys. Okay.